Welcome. In this video, we will explain why your child has his or her trach, what the most common causes for airway narrowing are, the surgical techniques to open the airway, and then eventually to safely remove your child's tracheostomy. Let's begin. Narrowing of the airway may occur at many levels, including the voice box, otherwise known as the larynx or the windpipe, and also known as the trachea. There are many causes of airway narrowing, ranging from children who were born with narrow airways to children who needed to be intubated on a ventilator for a period of time because they were born premature and their lungs needed to grow. Some children may have suffered from sepsis, an infection, or trauma and needed to be intubated while they healed. However, the very same tube that saves these children's lives while they develop and heal can also rub the airway and cause a scar to form, which can make breathing difficult and necessitate placement of a tracheostomy. The most common cause is a narrowing called stenosis from a history of intubation, which causes trauma and scarring. Narrowing that occurs just before the vocal cord is called subglottic stenosis. While most often caused by airway trauma and scar formation, this may also be present at birth in some rare cases. Lastly, there is a group of people, often older children or adolescents, without a known cause of stenosis. This is called idiopathic stenosis. Surgical intervention is required when the children start having trouble breathing or develop recurrent croup symptoms, which is usually when the narrowing involves more than 50% of the airway. These interventions are complex, and treatment is individualized to address each child's anatomy. Depending on the cause of narrowing, children may already have a tracheostomy tube in place, which is incorporated to the surgical plan. Children with stenotic airways will typically undergo examination of the upper and lower airways while asleep in the operating room, a procedure called bronchoscopy. This will help determine if the child is a candidate for airway repair, as well as help plan the extent of the surgery. Laryngotracheal Reconstruction, also called LTR, is a procedure that involves cutting into the upper airway and placing grafts in order to widen the airway. When thinking about LTR, we first ask what type of procedure should be performed. The general principles of LTR are as follows. The airway is exposed and the area of the narrowing is identified. This is most often performed in an open fashion, such that incisions are made in the neck to access the airway from the outside. In some children, neck incisions may be avoided and LTR can be completely performed from the inside using lasers or other endoscopic surgical instruments. Once the narrowing is in view, the doctor will decide how best to open it up. In some patients with very severe airway scarring, where the scar is far from the vocal cords, LTR may not be the right procedure, and another set of procedures called criciotracheal or tracheal resection may be performed. In others, where the scar is close to the vocal cords, traditional LTR or laryngotracheal reconstruction is the primary surgery. The frame of the airway is most often expanded without removing any tissue in order to not encourage any more scar formation. To do this, cuts are made either in front or the front and back of the airway to allow the area to be widened or dilated. Once the new shape is achieved, it is held open and supported using grafts. Grafts are most often taken from the patient's own rib tissue. Rib grafts are strong and cause very little long-term consequences to the patient when done correctly. A small incision is made in the lower chest to harvest this rib graft, and then the area is closed back up. A temporary small drain is left in the place to assist with the healing process. In order to allow the area to heal appropriately, a supporting stent must be left in place for at least 1 week while the area starts to heal. The type of stent depends upon which type of LTR surgery is performed. Once the repair is complete, the neck incisions are closed and a temporary small drain is left in the neck to assist with the healing process. Depending on the type of narrowing, the airway reconstruction surgery can be done in either 1 or 2 or what is now called a 1.5 stage procedure. In a single stage LTR, the area of narrowing is repaired and the existing tracheostomy tube, if present, is removed at the same time. After surgery, a breathing tube is kept in the airway as a stent to prevent collapse while the area starts to heal. Single-stage LTR is best for children without other serious medical problems, such as heart or lung abnormalities, and when the narrowing is localized to one specific area. The advantage of single-stage LTR is that no tracheostomy tube is left in place after surgery. However, this means that the breathing tube is the only thing keeping the airway secure and must remain in place with the child sedated for at least 1 week. In a double-stage LTR, the area of narrowing is repaired and the tracheostomy tube is left in place. A stent is inserted into the airway above the tracheostomy to prevent collapse while the area starts to heal. The tracheostomy tube and stent are removed at a later time once the healing process is finished. Double-stage LTR is preferred for children with severe or multi-level narrowing or when the child has other serious medical conditions. The advantage of a double-stage LTR is that the airway is secure with the tracheostomy tube, which allows for longer stenting and healing. However, the longer a stent stays in place, the higher the risk of granulation tissue. Most recently, a 1.5-stage LTR has been developed. The 1.5-stage LTR is a hybrid of the single and double-stage procedures. Here, both a breathing tube and a very small tracheostomy tube are left in place at the completion of the procedure. The advantage of a 1.5-stage LTR is the presence of a secure airway with a tracheostomy, as well as a decreased risk of granulation tissue. Some children are tracheostomy dependent not because of an airway narrowing or stenosis, but because of a severe collapse in the airway called tracheomalacia. There are several techniques available to help treat this and achieve eventual decannulation. A new technique developed at Mass Eye and Ear utilizes a resorable stent placed behind the airway to prevent the airway from collapsing with each breath in and out. Once placed, the patient can then be evaluated for decannulation. The stents are designed to last for a few months, and by then, a fibrous capsule has formed to keep the airway open with good structural support and to prevent collapse with breathing. Once airway reconstruction is complete and the airway is open, your child will undergo what is called a capping trial, where the tracheostomy is capped during the day first and then at night to be sure it is safe to remove the trach tube itself. Your doctor will give you careful instructions regarding how this will work, and so you can feel assured that when the tracheostomy tube is eventually removed, your child will be able to breathe all by themselves. It is important to remember that all children are different. The airway doctor will work with each child and his or her family to come up with the best option based on their unique anatomic needs.